Thanks, folks, for joining us for our webinar today. We're just letting everyone filter into the virtual room before we get started. Very excited to have a really great interest in this report and in the webinar, and we're looking forward to being able to share some of the findings and what we've learned from this really exciting piece of work with you shortly. All right, thank you everyone for joining us today for our webinar, Realising Access Towards Equitable Abortion and Contraception Access in Victoria. My name is Carolyn Mogharbel and my pronouns are she and her. I'm the manager of the 1800 My Options service at Women's Health Victoria. We're a statewide service that offers free and confidential information and pathways to care for contraception, pregnancy options, abortion and sexual health. Before we begin, I want to acknowledge the traditional custodians of the land that I'm on today, the Wurundjeri people of the Kulin Nation. And I extend that acknowledgement to the owners of the lands that people are joining us from across the state and across Australia today. I'd like to pay my respects to Aboriginal and Torres Strait Islander people, their culture and their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people who are with us today. I'd like to acknowledge the Wurundjeri people's continuing connection to, care for, protection of the lands and waters that we're privileged to live, work and play on. I'd also like to recognise that sovereignty was never ceded and we are beneficiaries of stolen land and dispossession that began over 200 years ago and continues today. This is an important time to reflect on how our work intersects with their ongoing connection to country and commitment to equity and justice, and also an important time to respect and learn from and follow the leadership of Aboriginal and Torres Strait Islander women and gender diverse people, particularly in the health space. So thank you all for joining us for this really important discussion. Today's webinar is focusing on the findings of Women's Health Victoria's Realising Access report, which sheds light on the inequities in abortion and contraception access across Victoria. We are truly honoured to have an incredible lineup of speakers and panellists who will share their insights and experiences with the Victorian sexual and reproductive health system today. Before we introduce them, I'm going to pass across to Women's Health Victoria's very own CEO, Sally Hasler, to say a few words. Thanks, Sally.
Thanks so much, Carolyn. And can I also acknowledge the traditional land that I'm joining from today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, and thank everyone for joining us for this important discussion. As Carolyn said, I'm Sally Hasler, the CEO of Women's Health Victoria, the proud partners and deliverers of the 1800 My Options service that Carolyn oversees and manages with an incredible team. We're the statewide feminist not-for-profit leading the pursuit of gender equity in health. The launch of the Realising Access report couldn't have come at a more critical time. And this year, we've seen fresh attacks on sexual and reproductive health rights in Australia and internationally. And it's deeply concerning to see abortion becoming politicised again in Australia. And while Victoria is a leader in SRH, this report and the broader context demonstrates that we can never be complacent. And even after 16 years of decriminalisation, a dedicated and expert SRH sector, a committed minister and significant investment, access is often tenuous. And this is particularly the case for disadvantaged communities. The Realising Access report shines a light on those systemic barriers impacting disadvantaged communities when it comes to accessing abortion and contraception services. And importantly, it doesn't just highlight inequities, it also offers recommendations to guide practice improvements, policy reform and future investments. I'd like to thank the Victorian Government for their support to fund the 1800 My Options service and this work. It's not every day as an advocacy organisation that a government joins with you in shining a light on access and demonstrates the government's commitment to genuinely improving outcomes. I'd also like to thank our expert speakers, Monika Sarder, Professor Danielle Mazza, Shannon Hill, Christina Edvardson, and Kath Hannon for joining us today, and thank all our guests for joining. And finally, I'd just like to call out and thank the expert, professional and highly dedicated 1800 My Options team, led by the remarkable Carolyn Mogharbel, who is with you as our facilitator today. This team, day in, day out, answers calls close to 8,000 this year to support people, many in difficult and really complex circumstances, to seek assistance to navigate access to essential healthcare. And I always like to quote Patty Moore, who told me the first time I met her that 1800 My Options was the best thing that ever happened to abortion access in Victoria. So on that note, it's now my pleasure to introduce Jill Buddy, the Director of Women's Health and Population Wellbeing at the Victorian Department of Health. Thanks.
Thank you so much, Sally. Really privileged to be here today, and also want to take the opportunity to pay my respects to traditional custodians of the lands. I'm also on the lands of the Wurundjeri people of the Kulin Nation. I pay my respects to elders past and present, and to anyone of Aboriginal Torres Strait Islander descent who's joining us today. So I'll just give you a quick overview. Some of you will be very familiar with some of the information that I'm about to talk to you about. So as many of you will be aware, May last year, the government committed $153.9 million to improve outcomes for girls and women across the state, health outcomes, and this expanded on previous investments in women's health, including access to sexual and reproductive health services, public health specialist clinics, and initiatives aimed at healthcare recruitment and training. So this investment is aimed to improve women's health and equity as a fundamental human right, and delivering high quality services and ensuring women have a choice in selecting the service and care that works best for their needs. And the investment further reinforces Victorian's position, as Sally mentioned, as a leader in healthcare reform, and allows us to innovate and collaborate. So one of the initiatives is about establishing 20 women's health clinics over the next 4 years, in addition to an Aboriginal women's health clinic and a mobile women's health clinic. So the first 5 clinics launched in April this year, and they're gradually expanding their services and hours of operation. And the second tranche of 5 clinics was announced in October and will commence services beginning in 2025. The additional 10 clinics will be rolled out over the next 2 years. The clinics provide multidisciplinary women's health services closer to home, including contraception and abortion care. So the clinics will include access to nurses, nurse practitioners, midwives, healthcare specialists, including gynecologists, urologists, allied health professionals, such as physios and pain support, social workers, psychologists, dietitians and care coordinators. Make it easier for women to access specialist care for conditions like endometriosis, pelvic pain, PCOS, heavy bleeding, incontinence, menopause and prolapse. We've also announced the mobile women's health clinic in September, and this will commence service delivery shortly in regional Victoria on board Breast Green Victoria's van Nina, which will visit the regions with a focus on First Nations women to offer them access to sexual and reproductive health services and breast cancer screening under the one roof. So women will be able to receive confidential, safe and free consultations for sexual health testing and treatment, contraception, medical abortion where possible, and referral to surgical abortion, as well as other local health services available in their community. The expansion of the women's sexual and reproductive health hubs has increased the number of hubs across the state to 20. 6 new hubs have been established this year, joining the current network of 14 in delivering sexual and reproductive nurse-led free or low-cost care, including contraception, medical abortion, referral for surgical abortion and sexual health testing and treatment. And just between July 2023 and June 2024, a total of over 8,500 women accessed these services. We also have 13 fully operational women's health and wellbeing support groups and groups set up across the Metro and Regional Victoria led by NGOs. And they vary in their scope with local community needs, offer peer-to-peer support programs and local connections for trusted advice and services for women seeking support across all life stages. The groups include support for young mums, women experiencing menopause, women with experience of abortion, so the Abortion Project, multicultural women, First Nations women, and women with experience of family violence and trauma. The government has also committed $18 million over the next 2 years to the 12 Victorian Women's Health Services to continue delivering women's health promotion and prevention activities, and that'll help improve women's sexual and reproductive health, minimise the risk of chronic illness and reduce the impact of family violence and promote gender equality in health. We also have women's health scholarships, so the workforce supporting the hubs and clinics such as the nurses, nurse practitioners, midwives, GPs are all benefiting from our Women's Health Scholarship Program, which is helping to address existing skills and knowledge gaps when it comes to women's health. More than 150 scholarships were distributed in 23-24, offering chances to upskill in areas like IUD insertion, sexual and reproductive health, pelvic physio training, menopause and PCOS. The scholarships also fund training to promote cultural safety and remove existing barriers for First Nations women, women from migrant and refugee backgrounds, and LGBTIQA+ communities. The scholarships program is available this year as well and has received over 100 requests from health professionals, and we're reviewing those, and that information will be going out very shortly. We're also, we benefit tremendously from partnering with the Clinical Champions program delivered by the Royal Women's Hospital to support women's health clinicians on the job. There's also funding for a women's health research initiative, and our understanding of women's health will be improved through investments into this health data and research. And we're currently finalising a business case for the first women's health research initiative in Victoria, and that will be presented later this year, even though there's not much of this year left. The Inquiry into Women's Pain, as a lot of you will be aware, this year we launched the Inquiry into Women's Pain. It was the first inquiry ever held in Australia to focus on women's pain conditions and their living and lived experience of pain and seeking pain care. The inquiry heard from over 13,000 Victorian girls, women carers and clinicians between January and September 2024, and highlighted that women face real and enduring challenges when seeking care and support for pain. The inquiry will deliver a report to the Victorian Women's Health Advisory Council in December 2024 for a critical decision on the next steps to address the issues women have shared with us. And the report will also be published in early 2025 to share the findings with the community. So thank you for that indulgence, but that was a quick snapshot of the work that we're doing currently. Thanks, Carolyn.
Thanks so much, Jill. So much exciting work happening across Victoria. Now, next, I'm really very pleased to introduce Monika Sarder, who is the lead author of the Realising Access report. Monika is a fabulous data insights analyst and founder of Sunshine Analytics, with over a decade of experience working across health, education and social purpose sectors. With a master's in statistics, a background in policy and specialised skills in mixed method approaches, we are very, very grateful to have had her lead this project with Women's Health Victoria. Monika, we are very excited to hear your presentation. The floor is yours. Thank you.
Thanks so much, Carolyn. First of all, I'd like to pay my respects to the Wurundjeri people and the Boonwurrung people on whose lands I'm on. Onto this project. In data analytics, it's really common to say, oh, you're shining a light on something. But with this piece of work, it really felt like we were illuminating something important, because the experiences that are captured in this data, the experiences of seeking abortions and access to contraception, these are things that women do, alone, quietly, and even sometimes in secret. So it was just a real privilege to be able to extract insights to help with needs-based planning for these experiences. The data set that we looked at, it was the first time that it had been published or explored, was at the 1-800 My Options data set. As mentioned before, this is an initiative that's funded by the Victorian government, and it was launched in March 2018 to fill a health information and referral pathways gap for sexual and reproductive health, or SRH services. We had a service seeker data set of over 30,000 people, mostly women. That's a trans and cis inclusive, although the service is open to all gender identifications. And most callers were looking for pathways for abortion services. And it was really important to look at this cohort because callers are primarily the people who are facing some sort of practical or informational barrier to enacting their reproductive preferences the way that they want. The second piece of the puzzle is the provider data set, and there's 725 providers listed at last count. And 1-800-MY-OPTIONS is very proactive in keeping this up to date. And this is the importance of this can't be underestimated, because in Victoria, with this data set, we can see what services are available and also when they're being taken away, which in this precarious environment is a really important accountability mechanism. The final piece of the puzzle was the overall access data, and this was drawn from the Women's Health Atlas. It's a separate product that Women's Health Victoria maintain, has over 100 indicators at local government area level of health and wellbeing, quantitative information over time. And we specifically looked at the service access for the services that were most inquired about, abortion and IUD and hormonal implant insertion. Just to note that we did not have surgical abortion data. This doesn't exist in an authority form because the MBS item for surgical abortion traditionally has been conflated with miscarriage because of historical criminalisation. So Women's Health Victoria really hopes that this can be rectified so that we can have better needs-based planning. Something that was really important in this research was to make up that we set up a framework to capture the compounding effects of living in a disadvantaged area and living in a regional area and having to travel, recognising that travel has a cost, and if those costs are borne by the people least able to maybe meet those costs, then we've got really a problem that's over and above a mere postcode lottery. So we set up this framework by setting up 4 categories of area, looking at local government areas. Within metro areas, we ranked, and regional areas, we ranked areas from most to least disadvantage using the ABS SAFER scores, and then just cut them in half so that we had that framework. We made sure that we contextualize our data in the huge host of work, research and work on the ground that's being done in this sector. We undertook an extensive literature review of a lot of work that's come out of, especially Sphere at Monash University, sort of on the shoulders of giants, and we're grateful to have 2 researchers from that organisation here today. We also undertook a qualitative survey of the 9 women's health regions so that we understood those localised nuances and barriers. And finally, we set up a advisory group to guide the project at different stages, and that was comprised of people who are subject matter experts, working in specific areas or on specific projects that are having really significant impacts and benefits to access. And again, we have 2 people who are part of that advisory group and undertaking that work here today on the panel. The service seeker sort of profile was comprised, as mentioned, most people were calling about abortion services. About 4% of people were calling about long-acting reversible contraception, mostly IUDs. Unsurprisingly, the age range was really focused on people between 15 and 44, but we did have people outside of that inquiring about a few different services, but that was about less than 1% were inquiring about kind of other things. We had 3% of callers who were identified as Aboriginal and Torres Strait Islander people, and something that we were pleased to see was that percentage has gone up by 50% in the last year, and that really indicates that Aboriginal and Torres Strait Islander people, that demographic does see 1-800-MY-OPTIONS as a useful and culturally relevant service. We had a lot of overseas callers, and we really had a lot of callers who, like disproportionate number, who are going to have financial barriers. So 48% of callers were low-income healthcare card holders within people who were callers who had Medicare eligible. Very few of them had private health insurance. So again, private clinics likely to be out of reach. And we also had a high number of callers who were visitors to Australia or asylum seekers. Again, that speaks to financial barriers, because even though most visitors will have overseas health cover when they come to visit Australia, reproductive health cover doesn't kick in until 12 months after arrival. So that kind of leaves visitors in no man's land for accessing or help accessing services. So that really sort of foregrounds the importance of having free and low cost services available so that people can enact their reproductive rights. Across Melbourne, we saw that within Melbourne, 70% more callers came from areas with a relatively high disadvantage compared to low disadvantage, and they were really concentrated in the north and west. These were also areas where the qualitative surveys from the health networks in the north and Gen West were saying abortion and LARC provision isn't keeping pace with demand in the region, and the hubs aren't necessarily keeping pace with demand in these regions. In regional areas, we also saw a high proportion of callers from areas that had been underserved and were in the high economic disadvantage grouping. Though one thing I just should mention is that there have been a lot of changes, and some of the good changes that were talked about. So this map, especially of the regional areas, will look different in 2024. Moving on to the providers, what is available? There's a range of different services that are all critical for meeting sexual and reproductive health needs for a range of services that are listed on 1-800. What I specifically wanted to focus on was for hospitals and practitioners, the narrowing of services that occurs when looking at the things that our callers are really contacting the service about. So whilst almost all services are, providing the oral contraceptive pill, STI screening, cervical screening, could be higher, but it's still fairly high. Once you get down to IUD insertion, medical abortion, it contracts, the number of providers contracts, and the number of hospitals providing surgical abortions at the time this snapshot was taken is quite low. And again, it's important to remember that this is among still relatively proactive providers, because they've said, hey, we're happy to be listed on 1-800 My Options. A scan of the data also showed that among GPs at the moment, around 17% prescribe medical abortions. So that's much lower than that 49% that we're seeing there. What we really wanted to understand was, among these low access services, what was the distribution of gaps? So what these bars show are the percentage of local government areas of each of the 4 types that don't have any locally listed service in that LGA, with green being metro and purple being regional. Just the text is quite small. So we did see that surgical abortion, or inaccessibility of surgical abortion, was quite low everywhere. When it came to medication abortion, prescription and pharmacy dispensing, and when it came to IUD insertion, there were a lot of provision gaps at regional areas, but these provision gaps were most stark in the most disadvantaged areas, with 60% of local government areas having, in that category, having no pharmacies, for example, that dispense medical abortion medication. For the report, we also really dug down into what abortion service providers look like to understand, what accessibility, then might look like. So we know that access is in large part determined by gestation. Medical abortion is able to be safely prescribed up to 9 weeks. However, frequently GPs or nurse practitioners will require an ultrasound or pathology test result to assess for certain risks. That, of course, can place quite a lot of burden on those underserved areas. We have to meet the requirements of multiple providers before you circle back to the original person writing the script. We also know that the number of surgical abortion providers, once you sort of hit that 12-week gestation point, just falls off a cliff. When we took the snapshot, there was only 15 providers who offered surgical abortion after 15 weeks, and only 5 of those were in regional areas. So accessibility is really determined by gestation in certain areas. What we thought was really important to understand in terms of who might be missing out on unwanted abortions is, well, what are the characteristics of people who are contacting the service at a later time point in their gestation, and is there something systemic going on? Because these are people that we really want to target and make sure that they have access to services so they can meet their reproductive needs in a timely fashion. So we ran a binomial model to look at predictors of contacting the service over 9 weeks. And we saw that, yes, there are characteristics that are statistically significant in sort of predicting that you're likely to be in this sort of challenging group. If you're under 18 years of age, you're 38% more likely to be contacting the service at this later stage. So potentially there's some real stressors leading up to that call, or taking that, being able to make that decision. If you're born overseas, you're more likely to be contacting the service at that later stage. If you are residing in a high disadvantaged metro area compared to a less disadvantaged metro area, you're more likely to have been calling at a later stage. Similarly, if you're in a low disadvantaged regional area, you're twice as likely to be over 9 weeks when you call, and high disadvantaged regional areas were 3 times as likely as residents of less disadvantaged areas to be calling at that stage. So really, really stark differences in that reproductive healthcare journey. A thing that 1-800 My Options does, which I think is incredibly important, is when callers raise particular challenges, that data is captured. It's not something that's screened for, it's just if people bring that information up in the chat. But it allows us to have a picture of sort of what's going on for people socially, economically and health-wise, that is happening alongside this decision to pursue a certain avenue of contraception or abortion or particular healthcare. But far and away, the challenge that was most frequently raised was financial insecurity. We also saw a lot of people raising the issue of mental health issues, having co-occurring complex medical health conditions, and also family violence. And a kind of smaller number, but it was still in the kind of the top 6 people who were struggling with alcohol and drug challenges and housing insecurity. These did vary over time, and we've seen financial insecurity in particular really increase in the last year. So that highlights that it's, as people are really feeling that cost of living, pinch, that is going to translate into lower access, most likely. Then we move to looking at what is the overall picture of demand for abortion. Again, we're only able to look at medical abortion because surgical abortion data is very hard to get and impossible to get across all kinds of providers. So just to understand that the picture, more than 1 in 4 abortions are medical abortions at present. So when we look at demand, or I guess realised demand, because it's the people who've wanted abortions and been able to access them in Victoria, we have persistently seen a greater demand in regional areas in the blue compared to Melbourne. And the other thing that we've seen is that within regional areas and metro areas, there's persistently more demand in more disadvantaged areas compared with less disadvantaged areas. So you kind of see overall there's a mismatch between where services are most available in those more advantaged metro areas and where, for a range of reasons, there's more demand. And that also goes to the long-acting reversible contraception provision picture, which is covered extensively in the report. Some good news. 1-800 My Options has significantly increased their listings of really all services, SRH services, since they were launched in March 2018, and that's especially in relation to medical abortion providers. And also there's been a 50% increase in the number of surgical abortion providers listed. We also took the opportunity of linking the data, the provider data over that 6-year period with the Women's Health Atlas Access data over that 6-year period to look at the effect of, over that time period, having at least one medical abortion provider listed in a local government area. And we were able to demonstrate that, yes, having at least one medical abortion provider listed increases access significantly. It's 1.9 per 1,000 women of reproductive age annually. To put that into context, the average is 6.3. So it significantly increases access for people who want them to be able to get the healthcare they need in place. And that's also the case with pharmacies that dispense. So it was again really, really good to be able to show that quantitatively initiatives are having impacts. Getting to implications and messages, there is, as we've heard, an incredible amount of ongoing great work that is being done in Victoria, like amazing, innovative work. But we still are experiencing, and it's not even just a postcode lottery, because that implies that disadvantage is random, but almost like a deterministic system where inequities in abortion and contraception are disproportionately impacting people who are more disadvantaged and underserved. We are seeing abortion provision gaps and limited access to free and low-cost provision having impact on reproductive human rights. In order to address this challenge in a way that really is targeted and effective, we do need good data, and we're fortunate to be able to have data from 1-800 My Options to be able to paint a picture of need. So I guess I'm really excited to be able to hear so much from the panel about all the cool targeted and specific research and work that is being done, and across not-for-profits, researchers and government. And in the interest of hearing more about that, I'll leave off here, and thank you very much for your time.
Thank you so much, Monika. Really appreciate the comprehensive overview of the findings and their implications to sexual and reproductive health care in Victoria. If we have some time at the end, we will open up the floor for some questions, and we have answered a question in the Q&A already, so feel free to put things in there if that's what you'd like to do at the moment. Otherwise, we are also happy to answer questions via email afterwards. So now, there's a lot to unpack in what Monika has spoken to us about today, a lot about inequity and equity and disadvantage and underserved communities. To help us have this discussion and consider what are the future implications for abortion and contraception access in Victoria, we have an amazing panel of guests, and it's my pleasure to introduce them now. So, first of all, we have Professor Danielle Mazza AM, who is the head of the Department of General Practice at Monash University and Director of the NHMRC-funded Spear Centre of Research Excellence in Women's Sexual and Reproductive Health in Primary Care. She is a nationally and internationally recognised leader in implementation, research and knowledge translation in the general practice setting, and has made significant, sustained and ongoing contributions to advance general practice and primary health care in Australia in the field of women's sexual and reproductive health. Welcome, Danielle. I'd also like to introduce Dr. Christina Edwardson, who is Associate Professor in the School of Nursing and Midwifery and the Judith Lumley Centre, La Trobe University, and investigator of the Sphere CRE. Christina has a background in nursing and a PhD in epidemiology and public health, and her main research focus is sexual and reproductive health. Welcome, Christina. I'd also like to introduce Kath Hannon, who is a nurse and midwife and the project manager of the Sexual and Reproductive Health Clinical Champions Project at the Royal Women's Hospital. The Clinical Champions Project works across Victoria and aims to increase access and equity to reproductive health services in the public health service system. The project provides statewide clinical leadership, expertise and mentoring activities to current and potential providers of medical and surgical abortion and long-acting reversible contraception. Thanks, Kath. And last but not least, we have Shannon Hill, who is the Sexual Health Advisor for Women's Health Grampians, and she is a very passionate advocate working to improve rural access to sexual and reproductive health services in the west of Victoria. With over 10 years' experience in the space, Shannon has been a part of significant research findings that highlight issues relating to conscientious objection, and most recently a report which captures the lived experience and voices of 110 women and gender diverse people accessing contraception and abortion services in the Grampians region. Now, panellists, I think it's a good time right now to seize the day. It's okay to be feisty, belligerent and challenge the status quo, because frankly, as we've seen from Monika's summary, the status quo is not serving women and gender diverse people when they're trying to access sexual and reproductive health services altogether equitably. So thank you for joining us, and let's dive into the discussion. So I've got a question for all of you for a start. I want to know what stood out to you the most when you were reading the Realising Access report. What was a key takeaway or finding that particularly resonated with you or challenged your perspective? And I might start with you, Danielle.
Thanks, Carolyn. So the report was excellent, and I commend it to everybody and congratulate Women's Health Victoria and Monika Sarder for her analysis of the data. I guess the most striking thing for me is having the evidence there of the direct correlation between level of disadvantage in the community and availability of services. This is really critical. As Monika pointed out, it isn't a lottery, really. It's very clearly linked, disadvantage to lack of access. And I think this gives, the policy, the need for the policy added kind of importance and momentum.
Thanks so much, Danielle. That's a really good point. Over to you, Christina. Tell us your thoughts and key takeaway.
Yeah, thank you, Carolyn, and thank you for giving me the opportunity to contribute to this discussion. Firstly, I would like to congratulate the authors on this very important report. It's a very impressive body of work and with very solid data from a range of sources, which gives a very important insight into the contraception and abortion landscapes in Victoria. I think the findings that stood out to me in this report was the service provision gaps, although some of this has been reported in other ways, the significance of these gaps are very clearly outlined, and their results regarding the service datasets are quite striking. So I think that's the key takeaway, and I agree with Danielle's comments as well. Thank you.
Thanks, Christina. Over to you, Kath.
Thanks, Caroline. As with the others, I want to congratulate Women's Health Victoria and 1800 My Options for undertaking the analysis and publishing the report, because we know that we lack robust data and how much we need it. And this report will help to close the evidence gap. What really struck me is that 87% of people who were ringing 1800 My Options were inquiring about abortion services. And for me, this highlights the essential role for 1800 My Options plays in supporting access to services and providing the information and supporting referral pathways for people who are accessing services.
Thank you. Thanks so much, Kath. How about you, Shannon?
I also agree with Kath. I remember a time where those things about service access were really anecdotal. It would be from the nurses on the ground. It would be from people calling women's health grampians when they didn't find what they needed. So having this sense of the overall picture of the state and the service system, it's the most comprehensive view we've ever had. And having that sense of the priority needs of the service seekers together with the areas of high disadvantage, it's so valuable to help us focus our efforts on where to go next. So it's an amazing report and hurting my brain because I need to think a lot about it.
Hurting in a good way, I hope, Shannon. So I've got a question for you now, Christina. Can you tell us how do the findings of the Realising Access report build on or contribute to the existing body of research in sexual and reproductive health and abortion access? And are there any new insights that have come out of this or patterns that stand out to you?
Oh, thank you, Carolyn. I think many of the trends we see in this report are consistent with or in agreement with trends identified in other studies from Australia and also internationally. This includes the shift towards increasing use of medication abortion relative to surgical abortion, since medication abortion was listed on the PBS. The strong geographical disparities in abortion method used, with high rates of medication abortion relative to surgical abortion in regional and remote areas. And this report contributes with new and novel data from callers and providers, which also contribute to explaining those previous findings and patterns we have observed both in Victoria and nationally. And to me, one of the important findings of this report was around the characteristics of abortion seekers over 9 weeks gestation. So these data are very unique, as I see it, and provide very important insights into these access issues. So the report shows that abortion seekers over 9 weeks were more likely to be from more disadvantaged backgrounds and regional and remote areas, or born overseas. But what the report also tells us is that women who experience disadvantage also are less likely to have the surgical abortion option available to them, particularly in regional areas. And this will have significant implications for those women presenting later in pregnancy. So we have in our previous research identified that there are differences in outcomes of unintended pregnancy between women from metropolitan areas and women living in regional and remote areas of Australia, with city residents significantly more likely to have an abortion as an outcome of that unintended pregnancy compared to remote and regional residents who are more likely to have a live birth. And I think this report on access to abortion can help explain those previous findings and indicate that there are women who do not have the abortion option available to them when they experience an unintended pregnancy. And I think this is an area we need to understand better, though, and one of the key research gaps we need to address. Another finding that stood out to me was the service seeker characteristics in relation to LARC inquiries. So the report demonstrates that there were quite big differences within the group of overseas-born women, with service seekers from English-speaking high-income countries more likely to inquire after LARC compared to Australian-born citizens, while overseas-born citizens from other countries were less likely to inquire after LARC than Australian-born citizens. And I think if these would have been grouped together, we wouldn't have seen much of a difference between foreign-born women and Australian-born women. I think what is really good in this report is that those groups have been disaggregated further, so we understand more specifically those needs for specific groups. And I think that's a really good thing the authors have done here, and that will help us tackle those challenges in relation to access and equity. And I think also value in this report is how the metropolitan and regional remote categorization has been divided further into low disadvantage and high disadvantage areas, which provides very good insight into access and equity issues. For example, in relation to the uptake of IUDs, that was very clear. Thank you.
Thanks so much, Christina. It's amazing how many questions it's also made us ask as well about what are the next research priorities for Women's Health Victoria. Now, Shannon, Women's Health Victoria's report is really quite data-driven, but I know that Women's Health Grampians recently launched the Tell Your Story report, which explores the lived experiences of women and gender-diverse people accessing abortion and contraception services in your region. So can you tell us the ways that realising access mirrors the lived experiences reported in Tell Your Story, but also some of the ways that it differs or adds to those stories?
Absolutely. I can see that both reports really complement the overall picture for service seekers. And to put it in a really simple way, I almost see the Realising Access report is kind of the start of the journey. And so what happens when I'm looking for the service, and Tell Your Story then brings in some of that lived experience. So describing what happened perhaps when I went and received service or didn't find the service I was looking for in my local area. So both reports very much mirror the geographic access challenges. So a common theme described in Tell Your Story was the majority of participants describing the burden of travel and financial cost. An example of that was 78% of participants indicated it would be difficult for them to afford an abortion, but also indicated it would be difficult for them to travel to a larger city. So you're really getting that sense of the financial stress at that time. And that percentage increased to 100% for those aged 18 to 22, so that younger bracket really feeling that more. And as Christina said, that going a bit further, that your Realising Access report gives us the picture of the impact of the on-flow effect when those referrals go outside the region. And in addition to that, the Realising Access report lets us learn a bit more about the under 18s that we weren't able to reach in our report. So getting to those specific concerns about the under 18s being twice as likely to be advanced in gestation and 5 times more likely to have experienced sexual assault. So again, giving us a sense of what the specific concerns might be for different groups and how we can better support those people.
Thanks so much, Shannon. That's really useful. And I'm also struck by considering how the impacts of affordability are going to be particularly difficult for those callers that are under 18 or abortion and contraception seekers under 18. The costs are insurmountable for a lot of people. So I'm going to ask you a question now, Danielle. And what I'm curious about is that it's clear that there are systemic barriers to equitable access, including the reliance on GPs as gatekeepers for abortion and contraception services. What opportunities do you see for addressing systemic challenges through changes to practice models, legislative reform, or other systemic solutions?
Thanks, Carolyn. Yeah, I agree that a lot of change is needed, and the way I like to think about it is to put it in 3 kind of buckets of change that's required. I think the first one that is demonstrated by the report so strikingly is the need for information amongst consumers of these services. And the very fact that 1-800 My Options is receiving so many calls, while it's great, it also means that people out there in the community are having trouble finding the information about services. So I think increasing consumer literacy, not only about where providers might be, but also about the kinds of services that are available to them is really important. The fact that medical abortion is available, that they need to get a move on in terms of getting access to services because of the gestational limit. The fact that a lot of consumers still don't know about the availability of telehealth as an option, which could address a lot of the issues related to lack of rural providers. So I think that focus on improving consumer literacy is really critical. The second issue is that the report highlights is the low number of providers, particularly in these disadvantaged and rural areas. And so I think initiatives to increase the number of providers in those, specifically in those targeted regions, are again really important. And one mechanism that we could consider to do that is actually commissioning services where we know they don't exist. We do that for other kinds of services like mental health services, drug and alcohol services. There's no reason why sexual and reproductive health services couldn't be commissioned as well. And also supporting more training of not only general practitioners, but also gynecologists who really need this training and are often not receiving it and not having the opportunity, even if they want to train in abortion care, to do so. But also amongst our nursing colleagues, midwives, nurse practitioners. I saw some interesting data from Judith Dean in Queensland this week around training for nurses and midwives in their curricula related to abortion care. And I think also, so apart from the provider issues, then there are the system issues, and we can address the challenges here, I think, from better regional level planning. And those who've heard me speak before, if you can see the bruises on my forehead about primary health networks and local hospital district areas, and really having a handle on that regional level provision planning pathways that are transparent for the local providers in the region so that women can rapidly gain access to services is really critical. I think all of these issues I think government is listening to more and more, and I'm very hopeful that we have a health minister in Victoria who's very keen to advance access on abortion provision, and we have a great team of people in the department who are also keen to make women's health services better. So I'm feeling hopeful that as a community we can bring about that change.
Thanks for that, Danielle. You're right on a number of fronts, and I think imagine if we actually took these data reports and took the work that's being done across the sector to assess need and assess demand and develop some population level needs-based health planning. We'd see a lot of these gaps being addressed and a lot of the issues being addressed. So on that note, Kath, I'm really interested in your perspective and experience. Can you tell us a bit about what challenges health professionals are facing in responding to SRH access inequities, and health professionals interested in GPs and gynecologists, obviously, but also nurses, nurse practitioners, endorsed midwives and midwives, pharmacists, etc. Thanks.
Thanks, Caroline. Yes, it's they're an important component of the health workforce and in terms of sexual reproductive health service delivery. And the report highlights the patients who are in touch with 1-800 My Options have complex lives. And for the patient who does reach a sexual and reproductive health services, it takes that team more time to identify and respond to their needs in order to provide quality, patient-centred and responsive care. And so where services are limited and fragmented, it takes time to advocate for that patient need, to find that ultrasound or to spend time with the interpreter service, to make a referral to social work if that service is even an option, to advocate for someone who is beyond the gestation limit and needs a surgical abortion. And so while this is happening in an economic climate where health services are required to do more with less, and I do know amongst the network, the Sexual and Reproductive Health Network that we're in contact with, they're small, they're very committed, and they really do their best to advocate for their patients in their care. But unfortunately, the burden falls upon a few services. And there's a tension between, managing individual patient needs and providing timely care and navigating a limited system or referral pathway. And as the report demonstrates so clearly, these issues are amplified in rural and sexual Victoria, where there are fewer services, less options, more obvious objection and obstruction, and more, and we can see from the data, more complex needs. But so for the sexual and reproductive health team providing these services, historically, this work is associated with negative cultural norms and shames associated with this type of work, and unfortunately that's created some isolation and fragmented workforce. And again, historically tended to be provided by a small but committed team to uphold services in their local area. And we think of those as the conscientious providers in the community. But the risk to this workforce is that unless we're able to build the service system, those providers become tired and overburdened and burnt out and potentially leave their role. But as Jill reported, we know that my feeling is that the landscape is changing, and I recognise the efforts of the state and federal government to shine the light on access and equity through policy and funding initiatives, but there's still a lot to be done, as the report demonstrates, to build a strong, sustainable and responsive service system, and to be financially viable for the workers that are in it also.
Awesome. Thanks, Kath. And shout out to that small but committed team of conscientious providers doing all this work. And also a shout out to the fact that most of these providers are women in the system, taking on the load of women's sexual and reproductive health care, alongside obviously some fabulous men. But as you can see from the panel, this is really something that's left in the hands of women to address this problem. I'm going to go slightly off script for a moment. Danielle, we've had a question in the Q&A. We talk a lot about increasing the number of GPs providing medication abortion, but how can we also bring pharmacists on board to dispense it? Because the report has shown that just like there are big gaps in prescribing medication abortion, particularly in rural areas, the gaps are bigger for dispensing. Danielle, how can we get pharmacists on board?
I think it needs a pharmacy champion within the profession to really drive this across the country. I think the Pharmaceutical Society of Australia, PSA, are generally very supportive of women's sexual and reproductive health issues being addressed in the pharmacy setting. But I don't think that there's been a real champion to bring it about. From what I've heard, a part of the issue is it's a bit chicken and egg in terms of supply, that pharmacists are reluctant to order stock in and have it sit on the shelves when they're unsure that they're actually going to sell it. And so it's a cost risk for them. And so I think another way of driving this is through these local regional pathways that can involve pharmacy as well as general practice and other providers in the region. And if they're all collaborating together on the development of the pathway, then they're more likely to be engaged and provide these services. So I think let's all tap our pharmacy colleagues on the shoulder who are in leadership positions and get them to speak out on this issue.
Yeah, thanks for that, Danielle. And I think it's really important to call out pharmacists as a really important part of addressing population health issues. Thank you. I'm throwing over to you now, Shannon. The report highlights significant inequities in access to abortion and contraception, and it's particularly profound for disadvantaged and rural communities. What do you see are the most necessary improvements for addressing those needs for rural sexual and reproductive health seekers?
What a big question. How long have you got? I really think when I was thinking about this, I thought the things that I see as the most necessary is that abortion provision. And it's so important to have choice, that we have both medical and surgical options as choice. Good visibility of services. So 1800 My Options is essential to that. I love the part in the report that talks about the multiplying effect when we have a service in place that the proof of more services being provided is clear. Those low cost, no cost options are super important. I think building out the network of services that can share the load across the state. So having services in places closer to where people need them also gives us the benefit of building a sustainable skilled workforce, as well as kind of sharing that load that Kath was talking about. I love conscientious providers. In Tell Your Story, overwhelmingly, we had the stories, the feelings of certainty, relief and gratitude when people had the most simple things, which are being empowered with information, feeling listened to, feeling confident that they can discuss options and that they could seek local, timely and affordable care. So an example of that was 88% of people who said that they could easily get an appointment with their local healthcare provider were confident that their confidentiality would be respected. Conversely, we had 17% of respondents that had no healthcare provider feeling confident about their confidentiality. So that local care really does seem to make a difference. And again, you know, that cost aspect of the impact of abortion when it's an unplanned expense, if you like, that perhaps we can't afford that extra burden of travel if we need to. So I think that's a short list. I'd like more things, but I think those building out of services, the sexual health hubs coming into play, I think it's really exciting to see the impact that has in the coming year ahead.
Yeah, absolutely. Thanks for that insight, Shannon. Christina, I'm really curious about how you see about your reflections on this report and the ways in which it's also raising questions about what we still don't know about the system and about the barriers to care. So from your perspective, what are the key research gaps that need to be addressed to better understand and tackle the challenges that are preventing people being able to access sexual and reproductive health services?
Thank you, Carolyn. Yeah, I think we do need better data on abortion trends to tackle challenges related to access to abortion and also contraception. So there is, as we know, limited data in Australia and in Victoria on abortion trends, especially surgical abortion, and available data either based on self-reports, which are subject to underreporting due to the stigma associated with abortion. Results from our research and also research internationally indicate very significant underreporting of abortions in self-report surveys, and also that those most vulnerable are more likely not to disclose having had an abortion through surveys. And this is problematic because it will skew our data and the number of abortions will be underestimated as well. On the other hand, the data we have, the administrative data sets, commonly lack detail on the characteristics of women having abortions, which limits interpretation and usability of such data. And combining those two data sources is possible through data linkage, but those processes are very complex due to the multiple levels of approvals needed. It's expensive and also time consuming, so that will delay getting those results out. So results will not be available until after a few years, which is not very practical. We currently don't know much about the factors that influence women's choices and decision-making following unintended pregnancy, whether to continue pregnancy or to choose an abortion. And if these systematically differ between rural and urban populations or other subpopulations, and to what extent the differences we see in our data and internationally as well is in relation to the outcome of unintended pregnancy is relate to constrained reproductive choices. And I think that's a very, very important area of research. And or if there are other factors that also influence and create those differences we see in data. As the report also highlights, we do need to better understand the factors associated with seeking abortion later and what can be done to improve earlier access for women independent of geographic location or other socio-demographic factors. I think the Women's Voices Through the Tell Your Story project that Shannon has talked about clearly indicates the struggles with multiple contact points and the delays associated with these, which leads to unnecessary delays to accessing abortion care and which might throw women beyond that 9-week medication abortion limit as well. So finding innovative ways to streamlining the processes for all women, independent of where they live, socio-demographic factors, I think should be a priority.
Thank you so much, Christina. Absolutely. Now, Kath, I'm interested in your perspective here, particularly as a nurse and midwife and also from the Clinical Champions Project and working in such a really nation-leading service as the Women's Hospital. What role can nurses and midwives play in abortion and other SRH care? And what changes do we need to see to make this happen and make this possible and bring nurses and midwives into this space in a more meaningful and effective way?
Yeah, thanks, Caroline. Yes, as you say, my background's in nursing and midwifery, and I I feel fairly enthusiastic for the role that nurses and midwives currently play and can potentially play a broader role also, given that there are around 500,000 nurses and midwives in Australia. They make up about 54% of the health practitioner workforce. So overall, there's a lot of us. Of course, the majority are going to working in hospital settings and a much smaller proportion in community health and outpatients and in primary care, and an even smaller proportion are in sexual and reproductive health roles. But as has been mentioned, we're fortunate in Victoria to have a small network of the 20 sexual and reproductive health hubs and the hospital-based sexual and reproductive health services. And the majority of these are nurse-led care. My feeling is that the nurse and midwifery workforce is critical to sexual and reproductive health access and equity, as they are able to offer patient-centred care. And depending on their funding model, have got flexibility to spend time with a patient or to understand their context and their needs and represent those to others in the healthcare team. And they also undertake a broad range of roles in sexual and reproductive health, such as triage, health assessment, health education, and supporting a patient to navigate the health service system. So for nurses and midwives, I would say that this current environment is ideal to support broadening out their scope and to look for opportunities to expand your scope of practice to incorporate sexual and reproductive health roles into practice. So look for the scholarships, the courses, the networks, the mentorship that is out there, and as well as to use your position within your own work setting to advocate for sexual health services. You know, for instance, we've talked about the Women's Health Atlas, you know, perhaps as a task, take on looking at the Women's Health Atlas and find out who is in your community, both providers and the demographics of who lives in your community, and do some advocacy to support their level of need wherever that's possible. And more broadly, to talk about abortion as unexceptional, routine and everyday healthcare to help normalise abortion and reproductive health. And in doing so, this helps to shift the default position around abortion being stigmatised. We also need more funding models that employ salaried nurses and midwives in sexual and reproductive health settings. And I was just hearing this week in terms of nurse practitioner MBS. MBS remuneration needs to be on par with medical providers, and this also needs to be financially sustainable. We also look to our peak professional and industrial bodies and colleges and universities to support advanced scope of practice. The TGA amendments last year paved the way for nurse practitioners, and now with formulary changes, midwives can independently provide early medical abortion. And there are a number of nurse practitioners currently in the hubs providing early medical abortion and LARC procedures, particularly IUD procedures, and potentially these in advanced scope midwives can also take on this sort of work. So there are lots of great examples of where nurses and midwives have stepped up to provide care where and when it's needed. And yeah, as I say, I would like to see the colleges and peak bodies provide a broader range of support to support advanced scope nursing and midwifery practice so that they can make best use of their skill set. And this has the potential to reduce the barriers to care, increase access and equity.
Thanks so much, Kath. There's a lot in that. We've also had some questions in the Q&A about training. for nurses and midwives and also for pharmacists. So I'm just going to highlight to everyone in attendance today that we can send things out to folks afterwards, but the AusCAPS network run by Sphere is a fabulous resource for looking for training through across the sector that has the most comprehensive list of training options that are available to people that are actually best practice and evidence informed, etc. So I'd really encourage people to look at AusCAPS, register, get involved with the discussions and learn some more from the wonderful experts at Sphere. I'm going to move on a little bit though. And Danielle, I've got a question for you now. So the report has emphasised the role of 1800 My Options in bridging the gaps and navigating the sexual and reproductive health service system. So how can 1800 My Options and the primary care system work together to better respond to those needs of underserved communities?
Yeah, I think 1800 My Options has a number of roles in relation to primary care and vice versa. So I think this kind of data can be used in a kind of a monitoring way to look at improvements over time on a regional basis and in a local area, and that information can go out to primary health networks that are responsible for localities, you know, the primary health networks should also be promoting 1800 My Options to consumers in their regions, putting it on the website, kind of explaining what the role of 1800 My Options is, and encouraging providers to actually list themselves on 1800 My Options so that women can get access to the services. So I think it works both ways. Women's Health Victoria can go out actively advising the regions and local players in primary care about what's happening in their locality, because you have such excellent information, and also primary care can support 1800 My Options in filling the very important gap that it does.
Thanks, Danielle. That's a really great insight, and very, very helpful. We're really keen to work across the system to improve access. We have had a question in the Q&A. Does AusCAPS take social workers as options counsellors, Danielle?
So at the moment, it's focused on people who have an AFRA registration. So it's people that are providing the service, and it's really geared to the clinical and kind of implementation issues of providing the service in a primary care practice. So our target audience is GPs, nurses, midwives, and community pharmacists.
Thank you so much. All right. We've also had another question in the Q&A, so I'm going to read it out. Let me know who wants to answer this. So Victoria is a progressive state with nation-leading investments in things like family violence and known to lead in SRH care. I'm going to add to that. Sorry, anonymous attendee. However, we're increasingly seeing restricting access to abortion being debated or suggested in parliaments around Australia, like in South Australia, as part of the Queensland election debate. Some federal MPs have brought this up. So how can we ensure that access to abortion continues to be a priority? Who wants to answer that?
Well, I think it depends how you vote, for one thing, and I think political advocacy is really important. I've heard the Health Minister in Victoria say that you know, the anti-abortion protesters are standing at the back entrance of Parliament and they have to go past them every day when they walk into work. And we know also that the anti-choice movement is very engaged in letter writing to local members on a continual basis. So it's in the face of politicians at a level that the pro-choice movement perhaps doesn't sufficiently recognise. I think my colleague Kirsten Black, I heard her on the health report last week talking about and reinforcing the fact that the majority of Australians support abortion access. And I think we've just got to keep pushing that forward all the time and keeping a front foot in dealing with all sides of politics, pointing that out.
And, you know, maybe write some supportive letters saying keep it open, keep it accessible, make it better for underserved communities. That's a really great answer. Does anyone else have anything they want to add to that point?
I'm also thinking about now is the time in the sense that the political landscape is so supportive in terms of, you know, policy and funding initiatives, that it's really time to build these services and really embed them within the health system, so it ultimately makes them harder to undo when they're, you know, if and when they're under attack. And yeah, like Danielle says, think carefully how you vote.
Yep, think about how you vote and make it a normal part of healthcare. Thank you so much, folks. Now, we've got one more question for the group. It's the same question for all of you, because I think it'd be really interesting to see how you're all responding to this one. So just bear with me while I find the right piece of paper. Here we go. The Realising Access report outlines key recommendations for improving access to abortion and contraception. So there's a number of recommendations in the report. I encourage anyone to have a look at them and see what their role is in those recommendations. But for the panel, which of these do you think would have the most immediate or impactful effect? What do you think, Kath?
I actually didn't prepare an answer for this one. I was hoping someone else was going to go first. I just go back to here's the moment. We've got politicians who, you know, I've heard Marianne Thomas say the A word. Yeah. In a couple of different forums that I've been in. So yeah, I think now's the time to build the service system, you know, support the conscientious providers to find like-minded providers to build the network to ultimately help support those people who are calling 1-800 My Options, who have complex lives, and yeah, just to support their access to timely abortion services.
Okay. Good answer on the spot. Shannon.
I want all the recommendations, but the one that stood out for me was that to continue to support expanded health service provision in regional and rural areas, to identify innovations that will result in greater capacity building and sustainable attraction and retention of health providers. So it's top of mind for me at the moment. We've got some regional partners who are trying to be very creative in breaking the mould that training has to happen in Melbourne. So trying to think differently about how we provide services, what's the most efficient way, looking at the likes of spheres models of care and how we can bring those into regions to make the best of what we have and what we can do.
Thank you so much. How about you, Christina?
Thank you. Yeah, I think my pick here on among the recommendations is for the Victorian and Australian government to expand access to low cost and no cost abortions and LOC service. because of the disparities we have seen in this report. I think that's a very important one. I would also say the recommendations to the Victorian government to expand surgical abortion provision in publicly funded hospitals to close gaps in service provision access. And my understanding, and correct me if I'm wrong, is that 75% of births happen in public hospitals, but less than 25% or just 21% of abortions. If that could be improved, that would be a big win.
I understand it's improved since the date of publication of that particular piece in 2022, I think. But I think we also need to be monitoring that, don't we, Christina? It's really important. Danielle, what are your thoughts?
Well, certainly to continue to fund and expand the funding of 1-800 My Options as such a critical part of the abortion infrastructure. I certainly, when I'm travelling around the country, hold up 1-800 My Options as the gold standard in information service provision, and you know, that other states should look to it to model off. I also agree with Christina, really having a much greater emphasis on surgical abortion provision in our public hospital system, and really having very clear service standards so that everybody knows what's expected of that hospital, what are the criteria for which they will undertake the procedure, how many they're doing, complete transparency across each hospital service, and that there's standards that are reported on, and here the again, Women's Health Victoria has a role in that monitoring and reporting of actually what's occurring in the system, so that we can continually keep improving in terms of access.
That's great. Thank you so much, folks. One more question. That was going to be my last, but we've had a really cool one come in on the Q&A. So this is true that you are all amazing advocates and leaders in this space, right? And we all know that it does get tiring and frustrating when the progress can be slow and when there is so much rhetoric in the public about taking away people's right to bodily autonomy. So tell us, how do you keep going? Like, what keeps you going? How do you keep the fire raging and the energy going? And how do you keep doing this work? Whoever wants to go.
Want me to jump in?
Yeah.
I had no idea that I would be doing this job for more than 10 years. So every time I think that I'm finished, there's something else that comes up. So your report's given me another something else, Carolyn. But I think the sector support too, I always feel really supported by my colleagues across the sector. So while I might work in isolation in a region, I always feel like I can pick up the phone and know that people care and want to do better, and that keeps me going. Absolutely.
Thank you.
Similar for me too, Shannon. I didn't think I'd be in this role for as long as I have, and sometimes it does get pretty tiring because it can be an isolated role. But there, you look around the room, this virtual room, and you know, you're my people that that gives me energy to continue to do the work. And it's the wins in terms of working with people in the network, not just advocates such as yourself, but also clinicians to, you know, support them to expand their scope. And you know, I can think of a couple of nurses who started out in a sort of narrow scope sexual and reproductive health role, and just taken opportunities either to study or to advocate for services within their own organisation, and now they're just really kicking goals. You know, we've heard about a nurse practitioner up in rural and regional Victoria in Swan Hill, who's you know, really holding up the service provision up there. So, you know, it's those sort of relationships and wins that give me the energy.
Yeah, thank you so much, Kat. Anyone else?
Yeah, I'm happy to go. Yeah, I think what's great about this area is that there are so many amazing people in this space across practice, policy, community, and research, and that is what has kept me in this area. And I think together we can make a big difference, and that is very that drives me to do work in this space.
Thank you. Danielle?
Yeah, look, for me, you know, women's sexual and reproductive health and the ability to control your reproduction is just fundamental to women's lives. It's been fundamental to my life, and I reflect back on the life of my mother and my grandmother and my aunties and my cousins, and you know, I can see the repercussions of this issue right through in my community also. So it's fundamental for me. It is the core issue, and it's a very complex issue that requires input from everybody, from all of their different perspectives: health professionals, consumers, policymakers, educators, and it's only if we work collaboratively and get everybody's input that we're actually going to solve it and make it better. And it's a great way to work in the team like that, and achieve better outcomes for women. So I find it exciting.
Thanks so much, Danielle. Thank you, everyone. It's really great to hear that when we're in the situation that we're in with these threats to our rights. So you're right. I think it's really a fundamental part of gender equity, isn't it? Is bodily autonomy and access to sexual and reproductive health care. And I'm really grateful for all of you, Danielle, Shannon, Christina, and Kath, for joining us as in this panel and sharing your expertise and insights into how we can use the findings from the report and continue to build a really effective and impactful and responsive sexual and reproductive health system in Victoria. And also a big thanks to Monika Sarder, Jill Buddy, Sally Hasler for joining us today for this session. Thank you to all of the participants as well for coming along, asking your questions, reading the report, listening to the findings and engaging in the discussion. We're all part of a bigger system, as has been just mentioned just now. And as the Realising Access report has highlighted, we're all part of addressing systemic inequities in health and particularly in abortion and contraception access, and particularly for disadvantaged and underserved communities. We'd really like to challenge you all to think about your role in that space and how you can make sure that these inequities don't continue to disadvantage underserved communities disproportionately in Victoria, but also further afield. On behalf of Women's Health Victoria, thank you to everybody for attending. We'll be emailing everyone with an evaluation link after the event, and we'll be really grateful if you'd share your feedback and let us know how you're working to apply these insights to your work. Please stay connected with Women's Health Victoria and 1-800-MY-OPTIONS via our social media for updates on future initiatives and events. Thank you, everybody, for attending.